All right, this is the fractures. Now, I didn't say fragility fractures, I just said fractures. All right, and it turns out these are data collected here in the United States looking at the incidence of fractures across one's lifespan. All right, so in red, those are the women, okay, and you all knew that. Oh, you were thinking about because we've been focused on osteoporotic or fragility fractures today, and we know that those accelerate both in men and women, but less so or later in life in men than women, okay? But we tend to forget this little peak right here, okay? And are blessed with this area in here. So let's start to use some of the phrases I'm going to be using. This is when we have achieved peak bone mass in our 30s and 40s. And so when you've heard this reference that we'll talk a little bit about T-scores, it's basically saying, how does my patient now compare to if he or she were in her mid or his mid-30s? Because fragility fractures aren't supposed to take place at that time. Now, you're all going, well, what the hell is he talking about, fragility? We know what's going on here. As I like to say, these are young men trying to impress others, okay? Turn on the TV on Saturday afternoons and these crazy sports, okay, are pretty much young men doing crazy things and then getting hurt, okay? And that's what we see. And even we can see it an 81-year-old that Dr. Kahn said up on a roof cleaning his roof, okay, and falls off and has a fracture. So those are fractures, though, that have to be thought about is where the bone is incapable of withstanding the force that's applied to it, okay? Now, in this case, these young men are applying huge loads to the skeleton in a stupid way, all right? And it exceeds the fact that they have not yet achieved peak bone strength. So it's a combination of both, all right? So what I'm going to sort of put in the context of, well, as endocrinologists and clinicians that don't have access to fancy screws and so on, is that we think about any fracture after the age of 50 to think about, well, they probably weren't doing something stupid or crazy. So maybe the situation they found themselves in really was something where reduced bone strength contributed to the fracture. And study after study shows that if you have osteoporosis, you're more likely to experience a fracture, a serious fracture, in a motor vehicle accident, okay? So we're going to be talking about that any fracture that you see over the age of 50, it should at least be in the back of the mind, oh, that was a bad motor vehicle accident. Maybe we should be thinking about this in some other context as well, all right? So with that in mind, then just put everybody on the same page, and I hope most of you are familiar with this cartoon. We're talking about osteoporosis now, a metabolic bone disorder that's robbed the bone of strength, is leading to susceptibility of fracture, is due to changes in the microarchitecture, okay? So that there's thinning of bone or complete loss of connectivity. And Dr. Kahn made a nice point that he said, you got to stick bone together if you want it to heal, all right? Well, if you start breaking trabecular struts and things like that, the osteoblasts responsible for making bone can't fly. There's no way they can start to connect this, all right? So again, our job is when we identify somebody with a fracture, think about, has some of this microarchitectural deterioration been taking place, and what can we do to slow it, okay, or prevent further? So we're thinking about in terms of osteoporosis is a fragility fracture, and for intents and purposes, usually you hear about at a ground level fall, okay? But too often we start to make excuses for, well, it was a ground level fall, but it was slippery and she was going fast when she sustained this Colles fracture, okay? Maybe, maybe not. Maybe there was some reduced bone mass present, all right? Why we're talking about, why you're all here listening to me is you're seeing it in your own practices. You're seeing this is happening much more, okay? Much more frequently. There are more old people around, and unfortunately, a consequence of living longer is that there's more bone resorption than there is bone formation going on. So there's a natural age-related decline in the amount of bone mass that can resist forces. But this is just showing you sort of pretty much close to what this prediction from over a decade ago, but you can see that there's nearly a 50% increase in the number of fractures that are taking place. Now, not fortunately, but many of those are spine fractures. We're not going to talk too much about it. In fact, I don't talk too much about my patients about spine fractures because they don't kill anybody, okay? What we're talking about are really preventing hip fractures that have significant morbidity and mortality. If we can prevent the hip fractures, we're going to prevent the vertebral fractures. But there's not a heck of a lot to be done about that, nor is there much in the cost of it. to society in terms of involving orthopedic surgeons to take care of the hip fracture, in terms of nursing home placement, as well as changes in the whole family dynamics. Finally, many of us may say, gosh, and we'll talk a little bit about towards the end, is maybe the best way to identify a patient is to identify them at their first fracture. And this comes from sort of a little bit of a morbid way of looking at morbidity, all right? So this is the morbidity of as we get older, okay? So fortunately, look around, most of this crowd is not even on this graph yet, okay? But for those of us who are on into the 50s and 60s and older, the lower solid gray represents just the morbidity associated with getting older. Things just don't work so well, we maybe a little more tendency to fall, etc. But that's the morbidity just as we get older. But notice what happens to the morbidity shown that's added onto that when you have a fracture, okay? So for example, maybe the first fracture is that wrist fracture. So for temporarily, life's not so good for you. You've got this tied up, it's difficult to open cans, do other things, get to a door, drive, and things like that. So there's a little bit of morbidity associated with it, but fortunately it heals, you're back to normal. You're back on that graph. But as you continue to age, notice that the second one, you kind of get back there, but you spend more time with sort of quantifiable morbidity. But notice as those fractures start to accumulate more and more, and you're not getting back to where your peers are who haven't had that fracture. So again, and again, I'm not telling you anything new, this is just another cartoon way of sort of looking at it. Why we need to get and intervene and be thinking about, is there something we can prevent the next one from? I teach my medical students fractures beget fractures, okay? If you find a patient with a fracture, it's very likely they're going to have another one. You've already defined to you that they lack either common sense, okay, and they're going to be up on that roof again, okay, or that they have microarchitectural change that they haven't noticed but contributed to that fracture. So fractures beget fractures. Identifying the one who has the fracture, you're going to pay off in terms of where we should intervene and where we should spend our efforts on. I wish I could tell you we can find the one before that, but screening, as we'll talk about, doesn't really work very well with the current tests that we have. 2 million, too many. If you do that math of the 5,500, we're talking about 2 million fractures this year. But more importantly, let's talk about hip fracture and what I call the 3 Ds, okay? The death associated with the debility and the destitution. Dr. Kahn alluded to earlier on about death. Okay, and these are data taken from Medicare surveys looking at mortality and then debility and then destitution, okay, that accompanies this. And they broke their subjects down in terms of the mortality, in terms of, you know, sort of relative measures of overall health. And so if they were sort of a community dwelling patient, they're taking care of themselves, running their own household, they had a 2 to 3-fold increased chance of dying the next year just because they had that hip fracture. Okay? And being rich didn't make any difference. If you weren't low income, it was about the same increase. So 2 to 3-fold increase of death in the next year that we can't say the hip fracture was responsible for, but is a marker of that. And there are agents now that have shown that if you can prevent the second hip fracture, you reduce mortality in these patients. But what about debility? The most expensive part of hip care, it turns out to be long-term care residency. We take these people out of their house and they are now living someplace else, cared for. And that's a 4-fold increase. If they were already managing their house, there's a 4-fold greater chance they're going to end up with that. And then finally, what we don't forget about is we make them poor, okay? So in terms of they weren't low income, they are now poor after is about a 2-fold simply just because of having that hip fracture. So to put in context why we have to be very aggressive about preventing hip fractures in this elderly population if we can. Now, what can we do about it? Well, we all think about, oh, okay, there's another example. You had a heart attack. What can we do about that? Everybody gets involved with preventing heart attacks. And these are number needed to treat to prevent a repeat heart attack or to prevent a death. And we're talking about beta blockers don't really prevent another event, but they have nearly a 50% reduction, okay, in death. That's why everybody gets a beta blocker, okay? Similarly, statins, ACE inhibitors, or even antiplatelet therapy, all of that have been shown. But notice that they're pushing anywhere between 40 and 150 to prevent a death, and 30 to 50 number needed to treat to prevent a repeat heart attack. A bisphosphonate in that population were in the same range, okay, of only needing to treat 40 to prevent the next hip fracture, or only needing to treat 120 to save a life. All right? So it's in the same context, but I don't see that we're being that aggressive. And part of that we're going to talk about, okay? This made the cover of New York Times, okay, some time ago, but basically that we used to be very aggressive, and I want to sort of argue a little bit with Dr. Kahn that his slides are a little bit out of date, because yes, when we were pushing bisphosphonates like crazy and thought there wasn't a problem with them, we did see a decline in hip fracture. But it's, as you'll see, it's going back up again, okay? This is looking at the likelihood of treating osteoporosis. Used to be in the golden days of the early 2000s, we might treat 40 out of every 100 that should have been treated. All right, so we were at 40%. Now, well, nearly 8 years ago, we're down at half that, at 20%. Though, during that same time, the number of women went up from 19 to 25 million, just women that we're talking about in that group. So, how can we identify patients at risk? When should we be thinking about it? Well, almost everybody, they just go, boom, oh, I've heard about your fancy test called bone densitometry, okay? And we frequently think, oh, bone densitometry, that must tell us about bone strength. And it does to some extent, all right? These are data, okay, that now have allowed, and now decades, FDA is approved and insurance companies pay for, because this does predict fracture risk, all right? So, shown on the left, okay, is looking at femoral neck bone mineral density, moving from small numbers to larger numbers on the right. And notice that as your bone density is lower, okay, your lifetime risk of fracture goes up. Or shown in fancy colors on the right side is this converted to T-scores, which again are the standard deviations that you are away from the mean of a 30-year-old man or woman appropriate for your sex. And notice that that magical minus 2.5 that everyone uses of a T-score of, oh, this is osteoporosis, is simply just the inflection point on this, okay? That it really starts, because it's exponential, it really starts zooming up, okay? But while a T-score of minus 1 does have a twofold increase, it's only a twofold increase. Now, here's the problem with bone densitometry. This is a complicated slide, but I'll try and take you through it, because there's many things trying to show on this, all right? This was basically a huge study looking at heel ultrasound as a surrogate for bone densitometry. But it was a quick and easy test that was done in thousands of doctors' offices across the United States. And basically, hi, hello, you're over the age of 40. Would you mind sticking your heel in this while you're waiting for the doctor? Okay. All right, and they got this information, and they said, by the way, can we check in with you and find out if you are going to have a fracture, okay? So, first off is the curve sort of in the dotted line. It just shows a normal standard distribution of bone mineral density in this group. Now, if we'd done this on 30-year-old people, that mean would be over at 0, because we'd be looking at healthy, normal 30-year-olds, and so that would be the distribution around that, and the mean would be 0 because the average age of them. But these were older women, and so no surprise, the mean is closer to about -1 T-score. So they've been they've aged a little bit, they've moved a little bit away, they've lost bone since that time. All right. Now, in the wide light gray bars, okay, is the relationship between bone density and the likelihood of fracture. So notice that that is the fracture rate per 1,000 person years is shown in the wider gray, okay? And if you make the cutoff from -2.5, those people have very high likelihood of having fracture, very high compared to all the rest of the population. But here's the problem. If you look at where the fractures are taking place, that only represents 18% of the fractures, the fragility fractures that took place in these women in the study, okay? 82% were missed. And this has been repeated in many other things. Bone density misses an awful lot, okay? It's only looking at the amount of bone, okay? And so any biomechanicist would say, well, of course, you're only looking at the quantity of something. The structural strength of anything depends on the quality as well, all right? And that's not anything that we can measure, okay? We don't have anything. We thought for a while we might find, but nothing works that's clinically valuable in terms of looking at architecture, the amount that quickly that turns over, whether it's mineralized. And probably the best example would be is someone with osteogenesis imperfecta, where they have a problem with collagen, okay? But their bone, their amount of bone is just fine. It's just not mineralized correctly, but they are very prone to fractures, even in the birth canal and later, and as a young child and later in life, and is associated with a dramatically shortened lifespan. So bone density is there, all right? Now, I always love to show this, okay? And then everyone says, okay, well, he's a biomechanicist. He says, oh, they're experts, they're engineers and things like that. But engineers are stupid as well, okay? Because there's another factor that's left off of here, and that's whether people fall or do stupid things, okay? So that's the other part of it that's present here. This is just looking at the strength of the bone itself, but then patients will do things as well, like being on a roof when you're 81 years old, that could lead to something. So, well, I prefer to sort of think about the various aspects as grouped in as such. Determinants of fragility fracture risk, we'll get into the pharmacologic management of it, but it has to do with both increased bone resorption and reduced bone formation. When we're at peak bone mass, those are perfectly balanced with each other. And we need that little bit of remodeling to take care of microarchitectural damage that takes place just throughout normal activities of daily living. But unfortunately, as we age, all of us, bone resorption stays there or higher, and bone formation, unfortunately, falls off for all of us as we get older. And there are many things that we can do that can upset that and make that discrepancy even worse. But there are other things that we or our patients do poorly. If we choose our parents very poorly, then genetics plays a role, all right? Unfortunately, that's not something we can correct in the office, but definitely this is a heritable disorder. Why we ask about what happened to mom and dad. There are things that you and I or they can do, and we'll go through a list of toxins that can expose. But what also aggravates this is either malnutrition, so think anorexia or other dietary changes where people choose to avoid the building blocks of bone, okay? Or just frailty of not getting enough exercise, and you need forces applied to that. So all of this is basically summarizing the things that go into this, all right? So what can we do to think about when we see a patient with a fracture, to think about, are there tests I can do, okay? He's already kind of poo-pooed the bone densitometry, okay? Because the patient's already had a fracture. I'm speaking in this room now to people who've already had a fracture. What do we do post-fracture, okay? As Dr. Kahn mentioned earlier, his study suggested a third, depending on where you look, it can be as high as 2/3 of subjects will have a simple metabolic issue, okay, that can be addressed, that it will cost $75 to test for, and many times doesn't even cost that. Most patients, okay, that end up will have had baseline chemistry, a CBC, a 25-hydroxyvitamin D, and if they're on thyroid hormone, a TSH sometime in the past year. And those tests can let you rule out renal osteodystrophy, hepatic osteodystrophy, primary hyperparathyroidism, vitamin D deficiency. The one that's missing in almost everyone's workup, and one that I try to stress to everyone if you're thinking about skeletal fragility, is are they absorbing the calcium they're taking in their diet, and are they holding onto it, or have they been peeing it out? Now, I'm not suggesting you do this on everybody, but someone who shows up with a fragility fracture, you wonder, how did they end up this place? Okay? I'll tell a little story. Over at the VA, they started hearing about, we got endocrinologists interested in osteoporosis, and fractures would come into the emergency room. And they go, oh goodness, okay, we got to take care of these guys, make sure they get on calcium, and then get them over to see the endocrinologist. Between the time of seeing in the emergency room and a month or 2 months later when they finally show up to see us in clinic, many of them were reporting, I've got flank pain now, I've got blood in my urine, okay? And these were men that had, unbeknownst to anybody, a renal calcium leak that was worsened by the treatment, okay? They didn't need more calcium, they needed a way for their kidneys to hold on and to retain what they'd been losing all of their life, okay? But similarly, many patients we identify who have normal serum calcium, normal vitamin D, have trivial amounts of calcium in the urine, and that indicates that they've not been taking it enough. If you're not taking it enough, then you have a high parathyroid hormone level, you have secondary hyperparathyroidism, and that is stimulating bone resorption and robbing calcium, okay, from the skeleton to make up for what the patient's not been taking in from their diet. So if the environment's not providing enough, the skeleton will provide that. So that's why the 24-hour urine, a very cheap test, the cheapest of all those up there, but rarely performed, can really tell you something. And as I said, it's not too much and if you assume that you're only a third of the time, it's only costing you $272 to identify a patient where you can make a major impact. All right? So just a little bit, since I've got a captive audience, I want to dispel some of the things you may or may not have heard about some of the simple things. I think about, with my patients, the sort of these basics: calcium, vitamin D, exercise, preventing falls, gaining weight, which I always find funny that this fat guy up here is telling this, but I love to look at these skinny patients come in and say, yeah, well, when I fall, I got plenty of padding. And that is an issue in terms of both padding, but also fat contributes in a complicated way to skeletal health. Okay? And then finally, by all means, stopping smoking. So let's first off, there's been too much about calcium, so you're going to get my bias. Okay, wait. You don't need my bias, you need an expert on this, okay? Some of this may be a little bit old for you, but Midnight Cowboy, it was a pretty amazing movie from last century. And Ratso shared that there are just two things: sunshine and coconut milk, okay? And he's talking about vitamin, well, no, he's not, but I'm telling you, he's talking about vitamin D and calcium, all right? So what's the story about that? We've heard so much: calcium is bad, causes heart disease, etc. Well, depending on the study you look at, it may possibly be that it could be, in some small studies it shows it is risk. Other studies show no, it's a benefit, okay? Why don't we take the grandmother of all studies, that being the Women's Health Initiative, where close to 40,000 women were given calcium supplements to see, will this make a difference? They were interested in heart disease, they were interested in cancer, they were interested in fractures. And lo and behold, okay, they found it impacted nothing, good or bad. So that's why you'll hear people say, you shouldn't be recommending calcium supplements. And they're absolutely right. But what they don't tell you about is the other part of this study, which they said, well, it was voluntary to sign up for this study. They didn't take calcium supplements away from anybody. They said, here, take this in addition to whatever you're doing. So it's no surprise that they became concerned that in a small subgroup of these women, they were even having kidney stones, much like my veterans that were showing up in our clinic after being given calcium supplements. Instead, they said, let's go back and look at the people who weren't taking any calcium supplements on their own, and they were then taking, we know they were taking what we were giving. So these were women who weren't so motivated about their health, that weren't taking calcium supplements, and what happened with them. And there you see a 35% reduction simply by giving them 800 milligrams of calcium, 800 to 1,000 milligrams of calcium a day. All right? So we should be giving calcium to those who are insufficient, okay? But we should not be making blanket recommendations. And the same applies to vitamin D, okay? We should be thinking about giving it to those who are insufficient, okay? And then it will make an impact. But throwing it to just putting it in the water for everybody, as any supplement is wrong-headed. Preventive Services Task Force came out and said, basically, well, we don't know, okay? So we're going to tell you that recommending against 1,000 milligrams of calcium or less than 400, that's stupid. Don't do that. That gets a D. But unfortunately, we've got too many crazy little studies that go both ways, okay? And they're going to say, so we're not going to, just insufficient evidence, all right? My experience, and I trust that most anyone who takes care of osteoporosis will see that you have a high risk of patients who are seeing you because of a fragility fracture, because they've not been getting in enough calcium or they've been losing too much calcium all of their life, as well as other things like they're on steroids or other things that can be contributing. All right? So what about the toxins? Immobilization, as you've heard from the surgeon or Dr. Khan earlier, get them up and moving. Clearly, if they had a hip fracture, there's many reasons to be up and moving. Pneumonia is pulmonary emboli, but it also stimulates new bone formation, okay? Why we're never going to Mars currently is because until they find out a way to be able to have muscles pull on bones, okay, no one's going to survive the trip there and back. God forbid they survive all the other problems that be, but their bones will be like jellyfish by the time they return if we can't find a way to maintain pull on bones. Cigarette smoking screws up estrogen metabolism. That's why people shouldn't smoke. Oh, maybe there are a few other reasons that you're aware of, but alcohol, definitely. The binge drinking that college kids are doing is taking a toll on their achievement of peak bone mass. We all get too much sodium, okay? There are pretzels over there in the midday, all right? We all get too much sodium in our diets. For every 100 milliequivalents of sodium that we have in our urine, we're losing 23, 25 milligrams of calcium. To make up for that in our diet, that's another 100 milligrams of calcium because we only absorb about 20 to 30% of it. But what about all the things that we can prescribe? Steroids number on the list, but pretty much it turns out if you're worried about ulcers, so you put on a proton pump inhibitor or a H2 blocker, impairs calcium absorption. We don't know what's going on with some of the psychoactive drugs like the serotonin reuptake inhibitors, but we think it has direct effects on bone cells themselves. And then finally, our diabetics getting exposed to either TZDs or the new kid on the block, the SGLT2 inhibitors, are clearly associated with increased risk in bad fractures like hip fractures. So there's much more to be known, but there are many medications that we can prescribe that cause problems. So that toxins and so on. Let's talk now about pharmacologic treatment, the adjustment of bone formation or bone resorption that we can do pharmacologically to benefit the patient, all right? So the guidelines for this are pretty simple, and I have for your slides, that if you've had a fracture and you're pretty convinced that this was a ground level fall, a fragility fracture, not induced by some crazy Red Bull associated event, okay, that's osteoporosis. Or to use, if you already have a T-score of below -2.5, to use that to make the diagnosis. But what about those who you think maybe have some of these other factors, the 82% of patients that didn't reach the -2.5 that we should do something about? Well, that comes from this FRAX, and I trust that some of you, and if those of you don't, we're going to go through a little bit of this fracture algorithm that was created by the World Health Organization to be able to get a handle on this increase in fragility fractures that are taking place across the world. And it's a very simple site that you can go to. You can get it as a app on your phone, but patients can just look it up on their computer, or many bone densitometry labs provide you this information with some simple questions that are getting at what we think are linked to changes in quality of bone. So like, have you fractured, has a parent fractured a hip, or have you had a previous fracture? That already starts to tell you you have increased risk, all right? So let's take the average 65-year-old woman, okay? She's had none of these things. She's average weight and height. It turns out that her 10-year risk of a major osteoporotic fracture, the humerus, the hip, the spine, is around 10%, or 1% per year. And her hip fracture rate is about 0.2% per year, or 1.6% over that, all right? This is the guideline that the Preventive Services Task Force said, you don't need to do a bone density up there, okay? If that bone density value hadn't been done, you'd get the same result, okay? It turns out that most 65-year-old women have a T-score between -1.8 and -2.2. They're healthy. So it turns out that adding the bone density result doesn't change this score. So what you do is you say, gosh, should I do a bone density? You're only 54, but could you have a skeleton that's more like a 65-year-old? Let's punch your numbers in with your history, and if you see that it exceeds 10% for major osteoporotic fracture or hip fracture, go ahead and get the bone density, because she's acting like a 65-year-old woman. And it's approved in that situation. Screening and the insurance companies say bone density can be done at that time, all right? But again, for this audience, I have this as sort of separate. If you already had a fracture, you don't need to be worrying about this stuff. She's already, or he's already in that group of a fragility fracture. But this is if you're thinking about someone where you might try to capture them before they've had a fracture. What happens to those risks when you start adding on steroids or previous fracture or genetics and so on? Like, now we're talking about a 44% chance over the next 10 years, or close to 5% per year. And similarly, a 9% chance in terms of hip fracture, or now about 1% per year, if you add all of those in. Okay? So indications again, 10-year major fracture risk greater than 20%, a hip fracture risk greater than 3%, or a T-score below -2.5. So what's available, all right? What's available are mostly on the side of slowing down resorption. We've got lots of different agents that can try to slow down either normal amount of resorption or excessive amount of resorption that's taking place, in the hopes that what limited bone formation is taking place can outstrip what bone resorption now is left, all right? So we have estrogen, as well as a variety of bisphosphonates, the alendronate, risedronate, abandronate, and zoledronic acid. Okay? And then we have better living through chemistry, a designer estrogen, a selective estrogen receptor modulator, raloxifene, and then a newer compound that is a monoclonal antibody that interferes with an agent that slows down, that speeds up bone resorption, part of the rank ligand signaling system. But on the other side, for increasing bone formation, we have but two. The one that's been around for a while is teriparatide, or PTH 1 to 34. Now, I don't want to scare anybody, but PTHRP has been linked to, not been linked, is a compound that was discovered in studying cancer patients, and it's a fetal oncogene, shouldn't be present in adults, but it works just like PTH, and in fact works quite good if you give it medicinally to treat osteoporosis as well in terms of an anabolic agent. So that's PTHRP, okay? So I should prepare you that if patients start looking at PTHRP, they're going to wonder, why are you giving me something that causes cancer? It doesn't cause cancer. It was discovered through cancer work. So to summarize them, okay, bottom line is all of these are quite effective. Hormone replacement therapy is very effective, but will never be used by anybody in this room in women over the age of 65. Okay, at least your insurers will appreciate that. Their study after study demonstrates increased strokes, heart attacks, and thromboembolic events in women over the age of 65 who are taking long-term hormone replacement therapy. And the beauty is we have other agents to use for those patients. And that would be raloxifene that does not associate with such cancers and does not seem to increase the rate of atherosclerotic cardiovascular events, but unfortunately it only works to prevent vertebral fractures. It doesn't seem to work to prevent hip fractures, and many patients complain of hot flashes because it interferes with normal estrogen cycling. The bisphosphonates have been around for a long time. They're very, very safe, okay? They can be administered either orally, once a week, once a day, once a week, once a month, as well as you can administer them parenterally once a year, okay? They clearly work on both vertebral and non-vertebral, including hip fractures. The oral ones, sometimes there's an issue with GI upset. And parenterally, if they've never seen a bisphosphonate before, prepare them. The first dose of a parenteral bisphosphonate may be associated with a flu-like reaction that only happens the one time. The body then says, oh, I know what you are, and the next time they get it, they won't get that reaction. As I said, denosumab is, again, a parenteral is given as a subcutaneous injection once every 6 months. It has some of the concerns because it is a monoclonal antibody and immunotherapy, but it's been very well tolerated. And then similarly, the PTH analogs are very, very effective, okay? Their problem is they come with a black box warning about concerns of osteogenic sarcoma that developed in animals exposed to high doses of these agents. And also, as we'll talk about, the cost, okay? So first-line agents, again, I hope most of you are familiar with, are pretty much the bisphosphonates, okay? A perimenopausal woman who's younger, not anywhere near the age of 65, you could also consider hormone replacement therapy for some of those other benefits. It is still considered the gold standard for bone. Unfortunately, it just has too many very worrisome side effects for long-term exposure. The second-line agents would be another bisphosphonate that's not used so often. We don't see Sally Field hawking this agent much more. It was never demonstrated to prevent hip fractures. And as I said, raloxifene, the designer estrogen, causes hot flashes that makes it difficult for many women. Calcitonin's been removed from the European distribution network because of concerns over nasopharyngeal cancer associated with the, and we just don't see too much of that being used. And then for patients with very high fracture rate, certainly we're looking for anabolic agents. We could use these, but that represents a high hurdle to get by with insurance companies, unfortunately, because of the very high expense. So I talked about the number needed to treat, and again, thinking about if you've already had a fracture and if your T-score is low, okay? Looking here, we're looking at if your T-score is below -2.5 and you've already had a fracture, you're talking about somewhere between a number needed to treat as low as 1 in 12 to 1 in 24, okay? And if you lump these all together and take advantage in terms of building in cost, you can see why generic alendronate is at the top of this list. Well tolerated, a good safety track record, okay, and is sort of the preferred treatment at roughly $100 a year, okay, for generic alendronate. Compare that to 21,000. Unfortunately, this is a little out of date. It's even more for teriparatide and for abaloparatide, but a difference of 2 logs in terms of the cost of using these agents. Not to take away, though, that teriparatide is, on this list, the only anabolic agent that's up there. But we're talking about $100 a year for 5 years on treating just number needed treat of 12 patients. You're talking about only $6,000 to prevent a fracture. Okay? So these are the patients that you'll be seeing, and you might be wondering, well, if I've dealt with a fragility fracture, why isn't this patient on a generic alendronate at some point? Or at least thinking about something like that. Okay? So they're safe and effective, they're available. Summary. Both of these are excellent. It's just the pragmatics of what I'm talking about is generally most insurance companies are looking for. And then the other thing I sort of just would like, if you are get involved or think about or see patients with this, to think about the right medication for the right patient at the right time. Okay? Pretty much once a fracture's occurred, you don't need to wait, assuming that you've dealt with those other workup that we talked about earlier. But certainly who's got a history of DVT, you're not going to put on something like an estrogen or even a designer estrogen. Thrombophlebitis is of increased risk in those patients. If you know that they have difficulty swallowing, okay, achalasia or some other esophageal stricture, do not put them on an oral bisphosphonate. That will just be doomed to fail. Okay? Sometimes people won't take medications. So a parenteral where you're in charge, it's prescribed once every 6 months or once a year, and you know that they get it, is a good way to go. Okay? So let me just show you what was going on that prompted that New York Times article. There have been great concerns raised about these agents. Now, I not want to get into alternative facts and so on like this, but these have been concerns raised over very rare occurrences. The first one was osteonecrosis of the jaw, and that definitely happens in cancer patients given osteoporosis doses of bisphosphonates every month instead of the way we prescribe once a year. And our patients don't have the immune compromise that cancer patients have. So practicing rheumatologists and endocrinologists just do not see osteonecrosis of the jaw, but you ask an oncologist using it for their patients, they do see it. But for us, we don't, it's not, it is related to dose as well as probably patient protoplasm in terms of their immune system. For a brief while, one study suggested that maybe atrial fibrillation was slightly increased in these patients. But that was quickly poo-pooed with a number of papers in the New England Journal. But the big one that Dr. Kahn referred to is this atypical femoral shaft fractures that has appropriately something that we should be aware of, okay? But I would point out that Dr. Kahn's example never saw a bisphosphonate. This all happened without. And the truth is, patients with osteoporosis get femoral shaft fractures. They're not atypical then. We're calling them atypical because, well, we put you on a bisphosphonate 5 years ago, and why did this happen? Okay? That must be atypical, all right? So there's certainly, we need to be thinking about it. In this case of an example, a 52-year-old woman, she has a Colles fracture. They go just osteopenia. She didn't really meet the criteria for aggressive treatment they did, but she had a family history and so on. She's recommended to take a healthy diet and so on, and she gets put on a weekly bisphosphonate. 11 years later, despite the fact that telling her primary care provider that her hips are killing her and aching, okay, and that's ignored, this happens. And the point to sort of take a look here is look at how dense these cortices are. And so there is something about turning off remodeling as you get older for long periods of time. So we do not recommend extended exposure to bisphosphonates. We're talking about maybe at most 5 years. But if you don't give a bisphosphonate, what's the consequence? These are rare, very rare fractures. Whoops, I apologize. Shown down here. Very low, 0.1, my thumb is too fat, 0.1%. But you will have prevented 40% of fractures. It was estimated in this 73-year-old woman who got started on this that you would have gone from a 15 to 18% likelihood of having a vertebral fracture at 5 years down to 7%, and a 3% risk of hip fracture down to 1%. okay? And even if you extend it out to 10 years, the tiny risk, if indeed these are connected, okay, or attributed to the bisphosphonate, is dwarfed by the benefit you have in preventing vertebral and especially hip fractures. So it's come with it. We talk about drug holidays, and so no one should stay on this extended, but we're talking about getting somebody on 5 years, okay, would be where you then start to think about this. And so again, for your handout, there are these slides sort of taking from our field. So very quickly, I just want to make you aware of, and I'm just going to sort of zip through this, about fracture liaison services, which seems to be probably the best way to go at this. We have our siloed of care, and the orthopedic surgeon sees this, the emergency room physician sees this, the clinician sees that, the specialist then sees something else. And there's been attempts at trying to coordinate all of this care as a way to deliver from when the event takes place to preventing further ones. And I attribute the American Academy of Orthopedic Surgeons as really championing this. Okay? And these are just examples of where, if you choose to use just take over the whole thing, comprehensive care, that'd be type A, versus you've had a fracture, you probably should talk to somebody about maybe seeing whether you should be on some calcium and get some exercise and go with God. And bottom line is, just to sort of show here, is where this has been adopted by Kaiser in California or by this Geisinger health system out in Pennsylvania or the Glasgow in Scotland, there have been substantial savings, a dramatic increase in bone density, and a dramatic reduction in fractures, and that contributes to a savings for those patients financially, which is what we need to convince administrators of this. So you may see that coming. So you've been very patient with me. Just to summarize, okay, that we're talking about 2 million too many. Despite what I've said about bone densitometry, use that along with fracs to augment that. Calcium and vitamin D should not be blanket prescribed. You can hurt as many as you can help. Make sure that you get that. Minimize toxins, and there's no reason to start fracture protection therapy right after the fracture. Let me close with that. Thank you. I've run over time, but there'll be time for questions later.